So it's really my pleasure, well, he's not late after all, to introduce Dr. Manisha Shah. She's assistant professor in the Department of Economics here at UC Irvine. She received a PhD at UC Berkeley and has been interested in the intersection of development, economics, applied microeconomics, and health policy. Recently, she's investigated the influence of economic incentives on risk behavior, choices, and health outcomes of poor women in developing countries. She also conducts research in the area of child health and has written papers on how child development affects maternal labor, supply decisions, as well as the allocation of resources within a household. She's collected data from fieldwork in Mexico, Ecuador, Brazil, Indonesia, and India. So if we're nice, maybe she'll take us with her on one of her frequent trips. Today she's going to talk to us about her research, randomized evaluation of a large-scale sanitation program in Indonesia. Welcome.
Thank you.
To thank her for
Thank you, Dele, and thanks for coming today. So I should mention also that I'm happy to take questions throughout the talk if you guys have any questions that come up. So as Dele mentioned, I'm going to be talking about some work that I've been doing actually the past few years in Indonesia, looking at some of the impacts of a randomized impact evaluation of a sanitation intervention. And I should also mention that this is joint work with Lisa Cameron, who's a colleague at Monash University in Melbourne. Okay, so just to give you a little motivation here about sort of child health issues in the developing world. I have some statistics here. One child dies every 15 seconds from diarrheal diseases in poor countries. Both diarrhea and acute lower respiratory infections account for for more than 40% of the 10 million annual deaths that occur among young children in poor countries. And while we know that that there is good evidence that improved sanitation decreases diarrheal diseases, we know that. But if we look at things like sanitation measures, we still see that a large proportion of the world's poor actually lack access to improved sanitation facilities. So again, I have this estimate here that 60% of the world's poor, or a little less than 3 billion people, actually lack access to improved sanitation. And in the country where we're working in Indonesia, in the last year, about 19 million people also lacked access to proper sanitation. And so if we think about the disease burden, the greatest disease burden of these lack of sort of access to sanitation fall on kids, right? So if we look at infants and children under 5 years old, the greatest burden of disease and death occurs amongst this population of children. And so of course the idea here is that diarrhea, by reducing normal food consumption and nutrient absorption, diarrheal diseases then can cause a significant cause of malnutrition, leading to potential impaired physical growth, impaired cognitive development growth, and then there's also reduced resistance to other types of infections and all sorts of other long-term health impacts, for example, long-term, GI disorders. So those are sort of the health impacts. If we also, I'm an economist, so I also like to think about a lot of the economic impacts. Though today this is a public health talk, so I'll be talking to you mostly about the public health outcomes we've been looking at. But just sort of as a little background and motivation, there's also a lot of important economic impacts we need to think about, right? There's just all the costs associated with illness, right? So people who are sick, they need to spend money to go see doctors, medical treatment, etc. And then there's also all the costs associated with productivity losses, right? So when kids are sick, they miss school. Miss school means the potential for long-term lower wages. When adults are sick, they miss work. So there's productivity losses in terms of missed days from work, missed wages, etc. And so while I said there is pretty good evidence that sanitation decreases diarrhea, a lot of the current evidence that is out there of the impacts, of the health impacts of sort of sanitation and hygiene interventions, they come from studies that impose very controlled conditions in fairly small populations over short time periods. And so part of this study, I guess, is to kind of look at a much larger program, look at a larger population, look longer term. So we're going to be following these households a little over 2 years. And then the other nice thing about the study I'm going to tell you about is we have a really nice design where we have this randomized design. And so we're actually going to be able to say something a bit better in terms of, we're going to argue that we have nice causal estimates of looking at the impacts of improved sanitation on health outcomes. Okay? And for those of you, I guess, who don't know where Indonesia is, this is Indonesia, and we're going to be doing work in the province of East Java, which is just this red circle here. All right, so let me give you a little background about what the actual intervention looks like, and then I'll tell you about what we did. So the program is called Total Sanitation and Sanitation Marketing. And this is a program that's being implemented by WSP, which is the Water and Sanitation Program, which is a group that basically comes under the umbrella of the World Bank. And they have, they have different offices throughout the developing world in different countries. And so these guys have been doing, water and sanitation work for a long time. But this program, so it's called TSSM, and in Indonesian it's actually called STOPS. This program is sort of a second generation program of CLTS. If any of you guys have heard of CLTS, it was community-led total sanitation. And so the idea behind the program, or what WSP was doing, was their sort of long-term goal is they want to roll out this program, the sanitation program, throughout the country. But they started with the population of rural East Java, which is actually, the third most populous province in Indonesia. And so they were piloting this program at a large scale. There's 25 million people that live in rural areas of East Java. And the goal of this program is basically to get communities to become ODF. So ODF stands for Open Defecation Free. And so there's still a lot of open defecation that goes on in rural communities, whether it's in agricultural fields. In East Java, it's primarily in rivers, because most of these villages are, they're based on these rivers, and so people do a lot of their open defecation in the rivers. And so just to show you some data here, this is at our, at baseline, we have about 65% of households that report to still practicing open defecation. And these bars are just, we're going to be looking at different districts in East Java. So this is just the variation across the different districts. But, you'll see that the prevalence of open defecation is still quite high. The other important thing to know about this program, TSSM, is that there's no funding for capital works. And so the idea here is that it's not that WSP is coming in and giving households money to build toilets. They don't do that. I guess, a little historical background for why they don't actually do that is in the 1980s, the Indonesian government under Suharto actually went in and built a lot of community toilets in rural villages in Indonesia, and they found that people didn't use them, they sort of fell apart. And so this new round of sanitation programs in Indonesia, the idea is they want these things to be demand-driven. They want people to demand to have change in their communities, but they want this to come from people themselves. There's very much this feeling, if we just go in and build people toilets, they won't use them, they won't care. But if people are actually spending their own money to build toilets, then we'll actually see more of this sort of technology adoption happening. Okay? And so I guess what that leads us to is the intervention is pretty when we heard about the interventions, I was sort of thinking, is this even going to work? Because it's really very much just a lot of information. So the way the intervention works is some guy comes into your community, and he spends a few days there. And the first day that he's there, he basically says, let's talk about your current sanitation practices. And so he, there's Mr. So-and-so, where does your household defecate? Mrs. So-and-so, where does your household defecate? And then they sort of walk around the community and they point out where these households defecate. And there's, they call this sort of the walk of shame. The idea is that there's a lot of ew and gross. And now let's think about in a year how much, you guys as a community, how much poo you guys generate, basically. And then, so that's kind of the first part of it. And then it's like, look, you guys are generating all these poo. Now let's look at your kids. They're running around barefoot. They're ingesting feces. They're getting sick. Don't you want to do something about this? What kind of change can you do? And then the idea is that this facilitator, this session is kind of called triggering. And the idea is that he's going to trigger change. And then what he does then is sort of spend time thinking about, if you guys do want to change, what can you do? Like, how can you build toilets? How much might it cost? Where could you get the supplies? And then so that's basically the intervention. But there's no, we're going to give you money to build toilets. It's if you want to build a toilet, let me help you plan how you might build a toilet, but you actually need to come up with the money to do that. Mm-hmm.
So, two things. So, first, do we have good data on the incidence of diarrheal disease per rate of open defecation in a community? I mean, I say
that's a great question.
So let's imagine that we were perfect public health professionals that had all the information. Is that information even available?
So no, and I think that's a really good question, because we also went into this wondering, in a way, these people right now are pooing in rivers, and there is a question about, if you actually build a latrine, what that does mean is that the poo then sits nearer to where you live, and if you're not cleaning that area properly, there is actually a potential where you could have kids, for example, could be more exposed to feces in this area versus if you're just going out walking to the river, you poo and it kind of goes away,
flows,
right? Exactly.
So
exactly.
You can say, as a population, we have a higher incidence, but that doesn't mean that they directly observe the negative health consequences. So that's one. And the second one is just to kind of emphasize your prior, that you really wouldn't expect. I mean, there's a lot of kind of health behavior theory that would say we don't expect much at all with this, because we're not giving anybody income, and presumably they had some information before you came in.
Exactly.
Okay, so just
so that's exactly what we're going to. Exactly. So we sort of walked into this thinking, is this even going to work? And I guess I should also give you the background of what we actually wanted to do. Was have an additional arm where we incentivize households, where not only, we sort of gave them the usual treatment, which was this information walk of shame thing, but we also said, and here's $50 to actually build a toilet. But WSP was very against that, and because this is sort of the program they run. We were coming in to evaluate the program they run, and they didn't want us changing it, which was fair enough, right? And I guess, which then brings me to this point of we still had to convince them to randomize, right? They don't randomly allocate their program, and when we came in saying we want to do this intervention, and let me step back also and give you a little more background about why we came in. So Bill and Melinda Gates Foundation is interested in investing a lot of money in water and sanitation right now, but it's sort of, they're not exactly sure where they should be investing the money to get their biggest bang for their buck. And so what they've done is they've funded a few evaluations of sanitation programs in a few developing countries. So this project, I'm the PI in Indonesia, and they're funding this work. They're funding another program in India, another one in Vietnam, another one in Tanzania. And so the idea is that they're going to look at all these evaluations, learn something about what works and what doesn't work, and then they can kind of go on and invest in sanitation. So because of that also, part of this was, okay, we're evaluating this program. These are all, every country is evaluating programs that currently exist and are, currently in the field. And so we met with a lot of resistance from WSP in terms of trying to sort of change what they're doing. But the nice thing that they did agree to do for us is that they did agree that for their phase 2 rollout, the part of the program that we, the phase of the program that we would be evaluating, they did let us randomly choose villages. And so the nice thing here is that for the evaluation that we're doing, we're actually able to compare, randomly chosen treatment villages with randomly chosen control villages. And so the idea with random selection, we're going to show you that because we have this random selection, the idea here is that the treatment and control villages in the absence of this intervention would otherwise be exactly the same. Okay? And our data pretty much does back that up. And so what's nice about that then is we don't have to do kind of one of these pre-post studies where then we might worry that other village level characteristics or other household level characteristics might be driving the differences in health outcomes that we observe. Okay?
Let me ask you a question about this.
Yes.
This scale. It's 20 million people in this region, and I don't remember the population of Indonesia. So what proportion of the country? It's a large scale.
Yeah, so this, so the Indonesian, it's about 10% of the total population. So yeah, Indonesia, the size of the population is fairly similar to the size of the U.S. Right, and so East Java, there's 29 rural districts in total, and then as I mentioned, the WSP was rolling out the program to all the rural districts. We got in phase 2. So we're evaluating phase 2 of the program. There were 10 districts that they had selected for phase 2, and in the end we have 8 districts that are participating in the study, and that's primarily just because of timing and our surveying and et cetera, et cetera. And so what we basically did was we went to each of the districts and we said, give us a list of anywhere from 30 to 70 villages where you're planning on, running this program. And then we got their list, and most of the district offices gave us lists between 40 and 70, and then what we did was from those lists we randomly selected 20 villages, where 10 of those villages became our treatment villages and 10 of those villages became our control villages. And then we kind of sent that information back to them and said, okay, now you can go and trigger in these treatment villages, but please try everything you can, that's possible not to trigger in the control villages. I'll show you some data on compliance in a minute. And then what we did was we had our survey firm that went into each of these villages, and they basically mapped the universe of households with kids under 5, and then we randomly sampled 13 households from each village, from each of our treatment and each of our control villages, which gives us about 2,100 households in the end who will be following over a few years. Okay. And so I guess, I don't know if you guys can see this. I don't think you really can. We have an RA who does nice GIS work for us, who made this map. And it's just to show you. So this is the province of East Java, and these are our 8 districts that we went to. And these, the kind of the diarrhea colors villages are our treatment villages, and then the kind of the purple are our control villages. But we have, this is just to kind of show you that we're going all over the province, and we have pretty nice geographic heterogeneity. So time frames. So we've been working on this project for quite a while. We got participation and agreement from all the districts in May through July 2008. Then we went in, after we gave them the list of the treatment and control villages, we went in, we ran our baseline surveys starting in August 2008. Ending in September 2008, and then right in October, those facilitator guys go into our treatment villages, they do their triggering, and then we kind of let these households sit for a while, right? Because we're interested to see if they're actually going to build a toilet or what's going to happen. And so you can't kind of go follow up really quickly because it might take households a while to build these toilets. And so we sort of sit for over 2 years. And then we go back in December 2010 and we run our endline survey to see what's happened in between. And I should mention that in between we were going back every few months to collect a few little indicators. Did the program actually come into your village? Were you guys even treated? We also collect some diarrhea measures over time because there's diarrhea changes a lot depending on seasonal issues, etc. And now we're just basically working on some of the final analysis.
Sorry,
okay.
I missed it. Were you able to give them the $50? Or not? No.
We were not.
Okay.
We were not. But the findings from this study will be good motivation for why we should be able to go back and do that. Because I'm basically going to show you the main reason that people don't build toilets is because they don't have the money to do it. So the outcomes I'm going to show you today are primarily health related. And so the idea here is we collected various levels of health outcomes. So the biggest movement you would quickly see for kids under 5 is diarrhea, right? And so we have diarrhea. We've also collected fecal samples to get at this issue of do we see any changes in parasites. And then if you, for example, observe these changes in diarrhea, well, then you might think that you would also see changes in anemia, right? Because if kids are keeping more of their food in and there's more nutrient absorption going on and iron is increasing, then maybe you'd see sort of improvements in anemia. And again, similarly, if there's less diarrhea happening, we collected information on height, weight, arm circumference, head circumference. Again, with the idea that if these kids are getting healthier, you should see some movement here on stunting and wasting measures. And then this is a much more longer term measure, right? So there's some evidence that you would see improvements in cognitive and motor development, again, if kids tend to be healthier. And so we had a psychologist working with us who developed there's this ages and stages questionnaire that's commonly used in rich countries, and so she sort of adapted it for the Indonesian version of it. Okay? And so we have, in terms of our baseline and endline survey, we've collected lots of information. We have all the general household level basic demography, labor market outcomes, income, and then of course, things on water supply, sanitation facilities, sanitation behavior. And I'm going to show you lots of data from these surveys. For the kids under 5, we collected all the health outcomes that I just mentioned in the previous slide. We have, as I mentioned, we also have this longitudinal data set where we went back every few months to see if how kind of treatment and control communities, you'd be worried, right, if we were picking up in this longitudinal survey that all of our control communities, for example, have been triggered or been treated. So we just wanted to keep an eye on what was going on there. And then we have the endline data set, which is basically the same as our baseline household survey, but we actually were able to also get some funding to collect fecal samples. So we didn't collect fecal samples in the baseline because it's pretty expensive to do that, but we were able to do that in the endline. And then we also have a community level survey, which again, I'll show you a few indicators from that. But here the idea was we just wanted to get a sense of, at the community level, what kind of public goods are already being provided, what sanitation looks like, what water looks like, and what other existing programs are, going on in the communities. Just to make, because again, you'd be worried, say maybe there's other sanitation programs going on that are affecting these outcomes. And so we just want to be able to make sure that what we're measuring as our treatment effect is actually the effect of this program and not other things. So I'm not going to show you, we have pages and pages of table in the paper showing that we do actually have very nice balance between our treatment and control households. So one thing you would be worried about is if at baseline before the program happens that you have big differences in treatment and control households. But we don't actually, in fact, have very many significant differences. And so this is just to give you an idea. Before the program goes in, income of these households look the same, access to sanitation looks the same, diarrhea rates look the same, anemia looks the same, all these other z-scores that we're going to generate from our height and weight measures look the same. And so it seems like we have pretty good balance across our treatment and control villages.
I thought you picked the non-control, the diarrhea colored part of the map. Wasn't it because they had higher incidence of diarrhea?
No, it was all, exactly. We didn't, so the only thing observables that we picked on was we needed to make sure that the households had children. And that was the only thing we stratified on. And then I think, the other thing attrition is a potential issue here, right? Is if we have, we clearly will have some attrition, but it matters again if you have differential attrition by treatment control status. So we spend some time looking at that in the data. And again, it doesn't seem to be the case. So we have about 8.5% of our households we lose when we go into the follow-up. But we look at characteristics of these households that we lose, and they don't look different across treatment control status. So it doesn't seem to be the case, that a lot of our control villages are moving or something like that. That doesn't seem to be the case. And then, we also, so we end up replacing these households in the end line. We do another sampling of new households. And then the other thing we do is, because our kids have aged out, we're going in over 2 years later, and remember, we're interested in looking at these health impacts of kids under 5, and a lot of our kids have kind of aged out of this group. So we also resample and get some more households with young kids in these same treatment and control villages. And so again, we need to make sure that these households don't look different than our households that are in the panel sample. And again, I'm not going to show you all the tables right now, but we do find that the differences in characteristics of the new sample are not significantly different than our old households. Okay, so this is just to show you guys some data on, where our treatment villages treated and where our control villages actually controls. And so we have 3 different sources of data we use to measure this. So we have, so the WSP data, this is actually the program guys who are going in and implementing the program. So they can tell us which programs they treated and which programs they didn't. So, this is the first column here where, so each district, we had 10 treatment villages and 10 control villages. So according to their data, about 83% of our treatment villages were triggered, and 4% of the control villages were also triggered. So there's 4% contamination here. But we also went in, they're the guys implementing, and so in some sense you kind of want an unbiased view of, who's being treated and who's not being treated. And so we have 2 different data sets. We have that longitudinal data set that I told you guys about, where we were going in every few months to ask households. So if we look at that data set, we get that about 63% of our households in the treatment villages were treated, and about 15% in the community villages were in the control villages were treated. So we're getting both higher rates of contamination and lower rates of triggering in the treatment villages. And then we have another, in our end line survey, where we went in at the very end, we also asked households about whether or not they were treated. And there we get about 66% say they were treated, and here we get about 14%, remain control. So, not bad, but clearly we don't have kind of 100% compliance here and 0% here. So there, which again is, in a real life program, you would expect that. And then the other thing, this is just, in this end line survey, we asked households if they knew about triggering. And again, you'll see that, there's not, this program isn't, it's not that, I don't know what the word is, not terribly strong, in that only, on average over our entire sample, only about 15% of households report to knowledge of triggering. There's, significant variation within each district. But you will see that it's not, that say 100% of households that were in a village that were triggered actually even know about the triggering. Because part of this is, okay, the guy shows up for a few days in your village, but you might not be there that day, right? You might not even attend. And so part of this is also, in some sense, it's a low exposure program. Okay, so this is our first... before, I have until 1, right?
Yeah.
So before I get to any of these health impacts, you first need to know if there were any sanitation impacts, right? Because if I show you that there were health impacts, but there's no sort of first stage and that you don't actually observe anyone building toilets or doing any change, you might wonder where these health impacts are coming from. And I've already told you that, this is in some sense a kind of low exposure program. And so if we look, our main, sanitation outcome here is, did you build a toilet or not in the past 2 years, right? And so this is basically, this top row here is that question. And so in our treatment villages, about 16% of households report to building a toilet in the past 2 years. And in our control villages, about 13% report to building a toilet in the past 2 years. And so the idea here that, and then we just look at the difference in these two means, and the difference, in fact, it is statistically significant. So households in treatment villages are about, 3 percentage points more likely to build a toilet. And so that's about a 20% increase, you know, in toilet construction. So it's not big by any means. You know, it's fairly small, but I think given the program, it's sort of what you would expect too. And then what we do is we break this up. So by the way, these are just the numbers of toilets that were actually built. So then we say, okay, let's look at these households that built these toilets and break it up by people who actually had no sanitation previously. Look at people who had unimproved sanitation previously, and then just people who had improved sanitation previously. So these are the guys who already have good sanitation but are just kind of building a new toilet, maybe because they're kind of the richer guys or they have the money to do it or whatever. And so here you'll notice that the greatest number of toilets are actually being built by people who already have improved sanitation. But the biggest difference across treatment and control is actually happening amongst those guys who did not have sanitation previously. So these are the guys, you know, in the treatment villages who are, you know, so here it's around 4% in the treatment versus 2.5% in the control. And this difference here is statistically significant, as is the one for guys who had unimproved sanitation previously. All right? Yes?
So could you differentiate between no sanitation and unimproved?
Mm-hmm. Yes, great question. I should have clarified that. So for improved sanitation, we're using, there's this WHO UNICEF Joint Monitoring Program definition of improved sanitation. And they basically say that it's improved sanitation when you have either a flush toilet or a latrine that either flows into a septic tank or a sewage system. When it's either a ventilated improved pit latrine, or when you have a pit latrine with a well that's covered by a concrete slab, or when you have a composting toilet. So those are all improved sanitation, and unimproved is basically anything else. And so in the context of Indonesia, it might be. So a lot of people will have what they call hanging toilets, where they'll build like an outhouse that hangs over the river. So you go, you poo, and then you know your poo goes straight into the river and it flows away. That would be an unimproved toilet. Or you know, if you just have a latrine that's not, you know, and the sewage is not going into a septic tank or kind of, you know, going somewhere where it should be. Okay. And so it is the case that, you know, a lot of people have unimproved sanitation, but part of the program might be to then kind of get them to improve their sanitation by installing maybe a septic tank, for example. Okay, and then the other big sanitation outcome we look at is open defecation, right? So as I mentioned, the goal of this program is to get people to reduce rates of open defecation. And so here we also see some movement, you know, not huge, but some movement. So in this first panel, we look at everyone. This is everyone, this is control, this is treatment. And so what you can see is that men are now significantly less likely to defecate in the open as are children. So overall, we're seeing this decrease in open defecation, but it's mostly being driven by men and children and not the women. And then we actually, you know, separate this by river and not on river, because as I mentioned, a lot of the open defecation is actually happening when you have access to close rivers. And you'll see that most of this change is actually being driven by these guys who live on rivers, in that, you know, again, men are significantly less likely now to be defecating when they live near rivers as are kids. There's not much movement going on with the women. We're not sure why, but I think part of it is, you know, women go to the river as more of a social thing. They wash clothes there, they hang out there together, and so, you know, because they're doing other things while they're there as well, they might also be, you know, defecating, but part of it is that they still have to go to the river to wash clothes, and so maybe if they're going to poo, they're still just going to go poo there, right? Whereas men and kids maybe now it's easier for them to change their behavior.
Mm-hmm. Just a measurement question.
Yes.
How internally valid is this question in terms of accurately relaying what they're behaving to do? What they do?
You mean like because it's just a self-report, and why should we believe what?
Yeah.
Sure.
I don't know. No, I don't know. Is there, have people looked at it? I think that would entail some observation, but I mean, I'm just.
So, I mean, the one thing I can tell you is there's actually not that much stigma associated with open defecation, and so I'll show you in terms of attitudes towards open defecation. people aren't embarrassed by it because it's just something that they
It's not
do.
a social desirability of reporting.
Exactly.
Like,
So
like sexual behavior, alcohol.
exactly. So I don't think, you know, exactly. So in the context of, yeah, like sex and condom use, you would definitely worry that people know you want them to say that you use condoms. Here, I think it's less of an issue just because I think it's not that stigmatized. But look, it's definitely, it is a self-report, and so, and we didn't do any observational stuff for this. We do observational stuff for hand washing, which I'll tell you about in a minute.
Quick question.
Yes.
So kind of on that end, so you said you took longitudinal data and you also took snapshots of data at the end, and the diarrhea rates you guys got, were those self-reported as well?
Yes.
Okay. Now, because open defecation may not have a stigma with it, but diarrhea may. So did you find?
Yeah. So I'm going to spend a while talking to you about our diarrhea results and whether or not they're real and we should believe them. And this will be one issue that I will get to. But you're absolutely right. The diarrhea is also self-reported. Any other questions? Okay, so we also, there's a lot of data that I'm not going to be able to show you today, but just to give you guys some idea, we also collected information on hand washing and drinking water. I should note that hand washing and drinking water, drinking water definitely not part of the program at all, so we shouldn't expect to see any big differences by treatment and control. And hand washing too, it's not a huge part of the program. The program focuses much more on, sanitation and building toilets. But there is a little bit of, and you should also wash your hands after you go to the bathroom. And so we did collect all that type of stuff. And, and if you ask people if they wash their hands after they go to the bathroom, 98% of people say they do. And then, but for some of this we actually had, so there, and I think part of this might also be this issue that Tim brings up, that everyone knows you should say, that you wash your hands after you go to the bathroom, but not necessarily everyone does every time. But we did have our enumerators go and actually look at hand washing facilities. So we would say, do you have a hand washing station? And a hand washing station is just somewhere where you wash your hands after you go to the bathroom. And then if the household would say yes, the enumerator would actually go and say, can you show it to me? And they would look to see if there's soap there and if there's running water and what kind of stuff is there. And, and water was available in most of the stations. Soap in less, again, which is what you would expect. But there's no significant difference in hand washing behavior or hand washing infrastructure by treatment and control villages. And so again, you wouldn't expect, if you see any differences in these health outcomes, it doesn't seem to be the case that it's because hand washing is driving it. And the same goes for drinking water. Interestingly, in rural Indonesia, households actually have pretty good access to good drinking water. So these guys aren't drinking water from the river. They have access to various sources of improved drinking water. And again, we don't see any differences between treatment and control communities in drinking water. So again, if you see differences in health outcomes, it doesn't seem to be the case that it's because of access to drinking water. And then here, we have, this is again getting at some of the issues of attitudes towards open defecation. How do people feel about open defecation? And we don't see, I think there's no significant differences across treatment and control communities. So this we asked them at the end line after the treatment has already happened, and you see that there's no big differences in how people feel about open defecation. And you'll notice here, that around 30% of people strongly agree with the fact that it's acceptable to practice open defecation if you don't have a toilet or latrine. But they also do seem to know that if you do have a toilet or facility in the village, it'll benefit the community as environmental pollution will be lessened. Most people I know normally defecate in a toilet latrine. And so it seems to be the case that people do understand, that open defecating is bad or unhealthy, but that it seems to be fairly okay if you don't have a toilet or a latrine. What else? We also asked caregivers' perception about causes of diarrhea to see, is it the case that our treatment villages just know more about causes and perceptions of diarrhea? So here we actually asked this question in the baseline as well as in the end line, and so we're able to do a difference in difference. And again, you'll find that in general, for most of these, there isn't any significant difference in caregivers' perception about causes of diarrhea. So most people seem to have a fairly good sense about what causes diarrhea. The only two significantly different measures here, you know, our treatment villages do seem to know that drinking unclean water is, you know, is a cause of diarrhea. But if you believe this result, the treatment villages also think that exposure to sun is a cause of diarrhea. So these might just be kind of, you know, spurious results. But in general, it seems to be the case that both treatment and control guys know about what these, you know, they have the knowledge, and I think they probably had the knowledge before this treatment even went in. In terms of, you know, at the end line we said, for those guys who didn't build a latrine, why didn't you build a latrine? And, you know, close to 50% of households report the high cost. And so this, you know, we've sort of been pushing this result to WSP as a reason in terms of why they might actually want to think about, you know, giving these households some money to build a latrine, because in fact, it's not very costly. So WSP estimates that it costs between $50 and $90 to build one of these, you know, toilets, which isn't that much money. And what's interesting is we asked in the end line, we wanted to get a perception from these households, like how costly they actually think it is to build a latrine. And you know, on average, they're reporting numbers around $135. So it does seem that households believe it costs a lot more than at least WSP estimates. It also, you know, some of the districts where we saw more construction or sort of more successful construction were providing access to cheap credit. And so this was happening, you know, within the community, where community members were getting together and doing these sort of rotating savings credit unions where different village members all contribute, and then every month someone gets to take home the pot of money. And so that was one way that villages dealt with the fact that, you know, they might have credit constraints and not be able to build a toilet. Okay, so let me, in the last 15 minutes I have, let me now move on to some health outcomes. So just to kind of summarize, it looks like we've had, you know, some sanitation impacts, in that we've seen significant increases in toilet building, significant decreases in ODF, but they haven't been that big, right? They've been, you know, okay. So let me show you now. We have diarrhea. So this is end-line data, the treatment and control. So treatment is green and control is red. And when you see stars, that means that there's actually statistical difference there. So there's no significant difference between ARI and ARLI for treatment and control. But you'll notice that in the end-line data, we do see that our treatment villages are significantly less likely to report having diarrhea prevalence in the last 7 days. And we actually use, so the WHO, they have sort of symptom-based measures of diarrhea. So we're not actually asking households, did your kid have diarrhea in the past? We do this for 2 days, 7 days, 24 hours. We have various measures of diarrhea. But I should note, we're doing this, we have this sort of child health calendar of health things. And so for diarrhea, you get that you had diarrhea if you either report to having your kid having 3 bowel movements in the last 24 hours, watery or soft stool, or mucus or blood in stool. So these are symptom-based definitions of diarrhea. And you'll notice that in all 3 of these, our treatment guys have, you know, are less likely to have 3 bowel movements. They're less likely to have mucus or blood in stool. And in the stool, and they're, you know, also less likely to have watery or soft stool. The mucus or blood in stool is the only statistical difference, but, you know, in the sort of the data looks the way it should if you believe the diarrhea results. You know, and then we had so we did similar for ARI where it's all symptom-based, but there's not much going on there. And then we just wanted to have some sort of placebo effect health outcomes, right? So you wouldn't expect to see anything happening with skin itching probably from a sanitation program, or like abrasion, scrapes, or bruising. And you know, you don't actually see any significant difference going on there.
Quick question.
Yes.
The last one.
Yes.
I mean, looking at that, I mean, it doesn't seem like there's it doesn't, I guess it doesn't look that significant, you know, and therefore, I mean, by your conclusion, it says, I mean, latrines are just as likely to increase your congestion and to have a runny nose than it would be to, you know, increase your risk of diarrhea.
So let me show you the regression. So these are all means right now. I'm going to put all of this into regression analysis, and then basically what you're going to see is that the only result that actually holds up is the diarrhea stuff, and this will go away. And so then, but you know, just we look at all these other health outcomes, right? So we look at anemia, hemoglobin, weight for age, height for age, and these are all just means, by the way. But there's just nothing going on, right? So in terms of just looking at means of all these different health outcomes that we've measured, the only one that kind of sticks with us is the diarrhea result. But then we say, well, let's actually put this all into, you know, regression format. And so we're going to estimate these intention to treat regressions. And so the idea here is we're just going to estimate the program impact off of a comparison of those communities who were treated relative to those communities who weren't treated. Okay, so it's just going to be this sort of average impact. And our Y is going to be our health outcome of interest or a sanitation outcome of interest. T is just going to be a dummy for whether or not your village was treated. So we'll run this first, which is, you know, and we'll put in, you know, sub-district community fixed effects because that was the level of our randomization. And then we're going to cluster all of our villages, all of our standard errors at the village level, again, because we randomized it at the village level. And then in other specifications, we'll also put in, you know, baseline controls for baseline and other different control variables. And so when we do that, you know, this is where so each of these is a different Y. So this is the dependent variable for when you're, you know, if you built a toilet in the past 2 years, and really it's kind of the strongest. The red means that it's statistically significant, and so all these other sanitation measures, it doesn't seem like that much is going on. And I should note that each column is just a slightly different specification with different, you know. Sometimes we control for baseline characteristics, sometimes we include other controls, sometimes we have fixed effects, and it's just, you know, to kind of show you how robust these results are. And the big robust result seems to be that, you know, treatment villages are significantly more likely to build toilet by around 3 percentage points, and that's about a 20% increase from the mean. The ODF result, remember I showed you the means where we had differences, but once we put it into regressions, we're actually losing statistical significance. The only ODF result which we get is, you know, if you are on a river, you're less likely to engage in open defecation. And hand washing behavior, again, we're not getting much, and we wouldn't expect to get that much because it wasn't a big component of the program. And so here's our diarrhea. So as I mentioned, we have, you know, 2-day diarrhea prevalence and 7-day diarrhea prevalence. And this is where, this is the ARI and ALRI. And again, you know, you'll notice that the diarrhea results, they're pretty strong. And they're pretty big. So the 7-day mean of diarrhea is around 4.6%. And so this is basically saying that, you know, if you're in a treatment village, you're 30% less likely to report to, you know, your kid having 7-day diarrhea prevalence. And then the 2-day result is even bigger because the mean there was about 3.4. So this is about a 40% decrease in 2-day diarrhea. And so so let me say, so we've had these sanitation impacts, which are not that big, this diarrhea result, which is pretty big. And so what we're, you know, what we've been spending time thinking about is, you know, are these results real? How much can we trust them? And so I want to spend 5 minutes now talking to you a little about what we're doing there. And I guess, you know, before I get to that, though, I should just quickly show you that in terms of all the other different health outcomes we have, there's not that much going on with the health outcomes. We do see the mucus or blood in stool, the refusal to eat. All of these things you would imagine are probably correlated with diarrhea. There is something here a little bit weird going on with increases in congestion or runny nose that I'm not sure, you know, what is exactly going on there. But again, none of the height, weight, anemia, cognitive development, nothing is going on. So the only real big health impact we've seen from this program, if we believe it, is the diarrhea. And so the important question I think that you guys have been pushing me on is, these are self-reports of diarrhea. How much can we trust them? And so as I mentioned to you in the end line, we did collect fecal samples, and those are actually being analyzed right now in the lab. So we have like half the data. We don't have the rest of it. And so, if we were able to kind of corroborate the diarrhea results, where we are finding that the fecal samples look a lot better for the kids in the treatment villages, then I think, you'd be much more likely to believe these big diarrhea results. We've also looked at, medical usage. So is it the fact, again, you're seeing these big diarrhea results. So do we see kids in these treatment villages being taken more to the doctor, or are they actually getting more treatment? And so what we do is we regress medical clinic use on a treatment dummy. And we do actually find that the diarrhea families in treatment groups are significantly more likely to actually use medical clinics when their kids have diarrhea symptoms. So, that's one thing that sort of corroborates the story we're telling. We're also, and this is something new that we're doing, we have, another reason you might see these big diarrhea impacts, if they exist, is because of this externality issue, right? It could be the case that, sure, not tons of people are building toilets, but if there's sort of this multiplier effect of this sort of externality of people, that you could observe these big decreases in diarrhea due to externalities. And so we have GPS data on households, and so what we're basically looking at things, like distances within households, distances to river, and we want to see if we can use some of that to actually explain these big decreases in diarrhea. And then the last thing we're doing, which I'll show you quickly, is we decided to look within districts, right? You could imagine that there's a lot of heterogeneity within district in terms of, how people built toilets and how they behaved. And so what we want to do is we want to look in the districts where we see lots of toilets being built. That's where you would expect the big diarrhea decreases to come from, right? And if you're observing big diarrhea decreases coming from districts where no toilets were built, then again, you might think that's a bit weird, and maybe these diarrhea results are just spurious or something. And so we do look at that. So we look at each of these is a district, and we have, our red is our treatment, and our blue is our control. And, I guess the only district where we're getting, where the increase in toilet construction here is significant is Madil. But remember, these are small sample sizes, and it's doing statistical tests with small sample sizes within districts is, it's a bit harder. But if you look, you'll see that in most of our districts, I guess, except for Bondowoso and Blitar, you do see that our treatment villages are building more toilets. We do the same thing, for ODF. And then what we do is we generate this table, right? And so we say, okay, in Jombang, there we do see open defecation going down, nothing much going on with diarrhea. In Blitar, we see open defecation going down, diarrhea is decreasing. And so we do that for each district. And in general, I think most of the districts look how you would expect. Banyuwangi is the one district where there's no significant sanitation improvement, but you're seeing big decreases in diarrhea. But though it's not significant, if you look at Banyuwangi, it does seem to be that, it is the case that more treatment villages are building, treatment households are building toilets. It's just that the difference isn't statistically significant. And so again, it seems that if you look kind of within district, we are getting results that that we would expect. But I think the big open question and the big thing that will sort of help us solve this question of whether or not the diarrhea results are real are these fecal samples, right? Because the fecal samples, they're not self-reports, and so if you're worried at all that people are misreporting their diarrhea symptoms, for example, we hope that that wouldn't be an issue with the fecal samples.
So in reference to the stool samples,
Mm-hmm.
so
I hope you're not going to ask me which parasites they're testing for because I was thinking I should write this down, but I.
It's all right. Well, so I mean, stool samples are it's really temporal. I mean, if you take a snapshot, you know, one day to the next can be completely different. So I guess you know, my thought in it is that information would be almost worthless because you're taking one snapshot. And I mean, and depending on the location, depending on whether or not it's rained within the past 24 hours, there's a whole host. And also because you can't test for the whole slate of everything that gets you sick, it just seems like there's so many variables in there that one sample before and after can't really tell you anything.
Well, so look, I mean, you know, this is sort of, we are people who are consulting on this project who know much more about like health and parasites than I do, have helped us think about, you know, which things they should be testing for, which I could definitely get you information on. But again, you're absolutely right that it's just one snapshot in time, and at the end of the day, that's really all that we could pay for. It's, you know, because as I'm sure you know, it's pretty expensive to collect poo samples from kids and get them to a lab and do all of that stuff. So it's, yeah.
Well, and they're also, I mean, on average, would there be rainy in the treatment communities and dry in the control communities? I mean, that's the issue, right? So it's, there can be a ton of measurement error and a lot of confounders to the extent that it's not contingent upon any geographic, you know, if your selection was unrelated to the geography and unrelated to these factors,
right.
You know, that's the only potentially, I mean, that I could imagine that also happening. But if you also talk about externalities of building toilets. So would that occur if more than one individual, more than one household uses the same toilet, or if you have like a super shedder deciding to use the toilet? So the one who actually ended up infecting everybody else decided to own up and get the toilet. And how would the data actually differentiate between those and a variety of other externalities?
It wouldn't. I mean, I think all we're going to be able to do, or all we can really look at, is this sort of more average externality issue. But we won't be able to disaggregate between story 1 and story 2 that you just told.
Do you know which one might be more compelling? I mean, based on what's happening in those communities, and I'm being clueless about that.
I mean, we could, you know.
Is there any kind of communal notion of a toilet, or is it really like a personal property? You know, this household buys this. You know,
It's definitely much more of a personal property. People don't want community toilets because there's this whole issue of who's going to clean it, and they get dirty, and you know, so people do want their toilet. I think there is maybe a little issue of there's some prestige associated with having your own toilet. So I would say for the most part it is private use toilets that people are building. In a few cases though you do have, we share our toilet with our neighbor because they're like close friends, and you know, and so then you get rid of some of these free riding issues that community toilets seem to face.
Were your stool samples from every child, or only those with diarrhea? I mean,
no, every child under the age of 5 within a household. Yeah.
Come on, quick question. So, what was the age that you were looking for in the children?
Oh, so it was, we have, all the health stuff is for kids under 5.
Okay, kids under 5. Okay.
Yeah.
So, I mean, one thought is you could, they're under 5, so maybe this, you know, this probably isn't applicable, but you could look at school attendance to try to back up.
Yeah, so exactly. So these are things that we're also looking at, things like we have things on school attendance, how much time maybe moms are spending caring for kids, is that changing, you know, labor market issues. So we're absolutely, yeah.
And then, the last thing is when you showed that, the graph of, you know, when you break it down by district, you know, there were 2 districts in particular that had significant gains. Did you guys look into what sort of maybe secondary factors went into them adopting improved sanitation? Maybe a baseline they had, or maybe they have, you know, a higher percentage education, maybe they have greater financial resources, so that, you know, given when they realize, Latrine can really help, you know, they actually have the resources to put them in place.
Right. I mean, we haven't yet, but it's definitely on the list of things to do in terms of, yes. Someone was telling us an interesting paper would just be exactly, like why are some districts successful when others aren't?
Yeah, because then you could really tailor
Mhm.
an intervention directly to that. And,
Yep.
and then you bring the point up, should we give them money? You could say,
Right.
well, this group has an average of $60, $70 income,
Yep.
per person per year, and
Mhm.
maybe you could
Mhm.
help direct the initiative that way.
Mhm. Absolutely. Yep. Mhm.
Are we in question mode, or do you want to finish?
I can keep taking questions.
Questions.
I'm basically almost done, so. Yep, Ben?
Well, I have a quick question that might help with the difference between the communities.
Yep.
How many different facilitators were there?
So that's a great question, right? So because you're absolutely right in that you could think that facilitators are going to drive success, and that if you had like a really charismatic guy coming into your, because we actually observed a lot of the interventions, and it was true that some of these guys were great, and I thought, God, I would build a toilet, and then others were sort of like, eh. And so we collected information on these facilitators in terms of like how charismatic do you think he was, and we haven't actually looked at that data yet, but that could also be one of these things predicting, why people are building toilets versus not. Because there were a lot of different facilitators, every district has its own set of facilitators. It's not that these guys are going, all across the province or anything.
Jumping off that, curious,
Mm-hmm.
how many, was there a ratio of, a facilitator per population? Because obviously going in and talking to 100
Yeah.
people as opposed to 1,000
Yeah.
would be a lot more effective.
Yeah. No, there were something like 25 to 30 facilitators across the province. But I don't know, I could easily find out though, how many were in each district, for example. I just know the province number. Mm-hmm.
I was struck by the difference between access to improved drinking water
Mm-hmm.
and lack of access to improved sanitation.
Mhm.
Because typically they go
Yep.
hand in hand.
Yep.
So I assume that the drinking water is communal and it's chlorinated, and so people go with their buckets to a central location, and it's free to them because it's provided by the government.
Yeah, so the Indonesian government, for some reason that I don't know why, there's been lots more water stuff happening than sanitation stuff. And so you're absolutely right that bad drinking water is not a huge issue in rural Indonesia.
Because running water, some scholars have said that's the most important thing
Mm-hmm.
in diarrhea prevention,
Mm-hmm.
as opposed to whether you're using a pit latrine. I
Right.
mean, if you have a pit latrine and you can wash your hands,
Right.
you're much better off
Right.
than.
Right. And you'll notice, no one's raised this, but the diarrheal prevalence in East Java, actually, we were surprised at how low it was.
Yeah.
It wasn't that high. That's not true in other provinces in Indonesia. You could go to poorer places where you would observe much higher rates of diarrhea. And part of, I think, why WSP decided to roll out the program first in East Java is because it's just an easier place to work in terms of the government actually functions and institutions function relatively well. And in some of these places where diarrhea prevalence is a lot higher, these places are also a lot poorer, and it would have been much harder to roll out the program, which are things that they're going to have to deal with now, though, as they actually do go into these poorer rural areas. Any other questions? I guess I'm over time, so I should probably wrap up.
Okay.
But yeah, I think I've said everything I needed to say. So thank you.
All right.